Good afternoon, everyone. Thank you for joining us for today's webinar. We're excited to share the fourth webinar in our series, Maximizing Federal Investments for Young Children. I'm Jen Bender with the BUILD Initiative, and I'll be handling the logistics on today's call. Audio for today's webinar is being broadcast through your computer speakers. Please ensure your speakers are turned to a comfortable volume. If you have any questions or comments throughout the session, please type them into the chat box. The presenters will monitor the chat and provide responses as they are able or following the call. At the conclusion of this webinar, you'll be redirected to a survey. We encourage you to take a moment to provide feedback about this webinar so that we may improve. This webinar is being recorded. Following the webinar, you'll receive an email with a link to the webinar, recording, and PowerPoint. And with that, I'll now turn it over to Harriet Dichter.
Thank you, Jen, and good afternoon, everyone. We really appreciate everyone dialing in for what we hope will be a great discussion about babies and toddlers and the systems that support them and their families. We have a really terrific set of speakers today as part of our series on looking at federal investments in young children. We've been looking at different ways that states and communities are using federal investments in early childhood. And today we get to start really at the beginning with babies and toddlers. These initiatives that we're going to talk about today span early childhood education, public health, mental health, maternal and child health, and home visiting, and also include extensive focus on family engagement. We picked them because they represent different facets of the work, but they are unified by a common understanding that a systems approach is really essential to being able to do this work. And so I want to give you just a brief intro to our speakers, very brief because it's most important that we spend our time hearing from them. We have Karen Finella with us, who works in California on Project Launch, and is going to be able to drill down much more deeply into helping us to understand how in California they're taking this nationally based work and are creating strong systems and services within several different local contexts. We have Janetta Green with us, who's from Alabama, where she runs the child care office for the state. And we'll be discussing a really innovative early Head Start child care partnership that also covers a huge number of communities throughout the state of Alabama and works not only with child care centers but also with family child care homes. And then we also have on our call Jenna O'Keefe, who is with the Annie E. Casey Foundation and has a long-standing involvement with an innovative public health, maternal and child health systems-based initiative in the city of Baltimore, the More for Healthy Babies, which she'll be able to share with us. We've organized our webinar into several sections for you, and throughout you may have questions and comments. And so we do want to encourage you to use the chat box because we have too many people on the call for just us to open up the lines. But we will try to pass along questions and see to make sure that we are responding to your questions. Before we get into the different kinds of issues we want to explore with you around collaborations, around systems financing, around outcomes, all kinds of things basically that relate to these endeavors, I've asked each speaker to give you an introduction to the work that she's spearheading. And so I'm going to start by turning things over for Janetta to talk to us to kind of give us a high-level view of what's happening in Alabama. Janetta, it's all yours.
Well, good afternoon, everyone, and I am just happy to be able to share with you what we're doing in Alabama around our Early Head Start Child Care Partnership Program. Alabama is one of just a few states who are a state-level grantee, and so we were awarded a grant in 2015, and our goals around that program is pretty much what the federal goals are, but in Alabama, how we are being able to implement and make sure that those high-level goals are taking place may be a little different. First of all, it's increasing the number of providers that can meet the highest standards of quality for infant and toddlers. And so we're doing that by layering the comprehensive services and other aspects of early Head Start into our private child care and our child care programs. By doing that, that combines the strengths of both of those programs. One of the things we've done is put a very big emphasis on family child care as well as center child care, so that we're going across the spectrum of those two sectors of the child care community. Layering funding, one of the purposes of the Early Head Start Child Care Partnership is this ability to layer the Head Start funding along with the Child Care Subsidy Program, our CCDF funding. So in our layering funding, we're providing those comprehensive services and those high-quality learning environments, and we're doing that by being able to combine those two funding streams to help those providers who participate get the maximum impact of the funding they need to increase to those higher levels of quality. We're also, Early Head Start is all about comprehensive services, and so we are integrating that into our child care and our family child care settings. So it's very encouraging when you see the type of things that those programs are now doing around family engagement, around services to parents, resources for parents, home visits with parents and families, those things that we're seeing happening now because we're integrating those comprehensive services into these into your traditional child care and family child care settings. And next slide. So another thing that part of our program, our funded enrollment is 566 children. 198 of those children are in family child care, and 368 are in our center child care settings. In our grant proposal, we proposed that 80% of the children would receive child care subsidy. That was a very ambitious goal, but we have been able to maintain it. And currently 84% of the families receive child care subsidy. So those providers continue to have that layering of what we're providing through Early Head Start, but they're continuing to receive the benefits of the child care subsidy program as well. Those 368 children are in 20 child care centers, and they're 198 are in 50 family child care homes. We have a total of 99 classrooms, but we are very large in that we have programs in 29 of our 67 counties. So we literally are from the northern part of Alabama to the southern part of Alabama, like to say from Madison County in North Alabama to Baldwin County in South Alabama. We have Early Head Start Child Care Partnership classrooms all across the state of Alabama. So that's a unique part, but I think the Early Head Start Child Care Partnership, one of the uniqueness of it is what we were able to do, especially in rural counties that we may not have had that opportunity to do before with our infants and toddlers.
Thank you, Janetta. Can we move on now to hear a little bit about California Project Launch?
Yes. Good morning to those of you in the western half of the country, and good afternoon to those of you in the east. Project Launch, for those of you who don't know it, stands for Linking Actions for Unmet Needs in Children's Health. And it's grounded in a public health approach with the goal of supporting infrastructures needed to improve coordination across the child-serving systems and to increase access to high-quality prevention and wellness promotion services for very young children and their families. It was designed to promote wellness in young kids ages birth to 8, and it is involved with integrating systems to address unmet needs for children's health and well-being. It's got a focus on children, families, and communities that are at high risk of trauma, and it promotes wellness, prevents mental, emotional, and behavioral disorders, and supports the early detection and referral to needed resources. Next slide. So in 2008, the Substance Abuse and Mental Health Services Administration, SAMHSA, funded Launch in 55 sites, including California. And then in 2015, SAMHSA funded 5 of the original 55 sites to replicate innovative innovative and promising practices that came out of the original launch efforts. California Department of Public Health Maternal Child and Adolescent Health Branch was one of the 5 sites selected to replicate 3 of the successful strategies that we used. And those were integrating early childhood systems at the local and state levels to promote identification, referral, access to and engagement with needed resources. The second strategy is family cafes, which are designed to strengthen families, connect them to resources, and support the development of parent leaders. And the third is around integrating mental health consultation into home visiting programs to support both families and home visitors themselves. Thank you.
Thank you, Karen. And last, we're going to hear a little bit about, now we've gone from the South to California and we're going to the East Coast. And so we'll hear a little bit about the Baltimore work.
Thanks, Harriet. Hi, everybody. My name's Jenna O'Keefe, and I'll just give a little background on this work in Baltimore, which is a little bit different from my colleagues Karen and Janetta, because this is a Baltimore City-focused effort as opposed to statewide, although this work does partner with many statewide partners. The overall outcomes are Baltimore City. So Be More for Healthy Babies is Baltimore City's citywide initiative that all of Baltimore's babies are born healthy and grow and thrive in healthy families. Wide range of partners and many partners, which we'll get to later. The intended results of this are the overall result is, of course, to reduce the infant mortality rate in Baltimore City. There are 3 top causes of the high infant mortality in Baltimore City, and those are preterm births, low birth weight, and sleep-related deaths. So the intent is to decrease those 3 and to improve some of those life course outcomes that you can see listed below around behavior change in the home, family literacy, changing services so that they're more trauma informed. And we'll get to more complexity later in the presentation. There were some pretty specifically articulated goals for the first 7 or 8 years of this initiative. You can see them listed there. They're, reducing the number of deaths from unsafe sleep by 30%. For example, other goals for teen births, preterm birth, and low birth weight. I just wanted to note that we are about 1 month away from having a completed strategic refresh document that is updating this work going forward for the next 5-10 years. And so the timing of this presentation is just a little behind, a little too early for all of that to be in place for this presentation. But the next slide gives you a little bit of a sense of some of the guiding principles that Be More for Healthy Babies uses. It's really a comprehensive approach, life course approach, dividing up life course from preconception to pregnancy to postpartum, looking at a whole bunch of different high impact areas that affect infant mortality rate, including safe sleep to access to prenatal care, substance use disorder, mental health, birth spacing, all of those things which many of you are working on in your work. Many other guiding principles there, including making sure that we're leading with a race equity lens and decreasing the disparity in these different outcomes, and of course focusing on cross-sector collaboration and systems focus. Also want to draw your attention to number 6, community and client involvement, which is something that has increased quite a bit over the life of this work. And then if we go on to the next slide, I just wanted to highlight that the theory of change that Be More for Healthy Babies has used in Baltimore is using this multi-level framework where we're not just focusing on individuals or on specific programs, but really looking at policies, services, community, and individual levels of intervention all at the same time and on all of the different content areas that we're focusing on and in conjunction with many partners. Great. So thank you.
Thank you. So now we've had a little introduction to each of the initiatives that we're talking about today. And we thought that the next thing that would be helpful as we're in our exploration of these strong systems-based initiatives is to hear a little bit more about community context. So we're going to do that by kicking it off with Alabama.
All right, so when we look at Alabama and our community, we're mostly a rural state. So this concept is looking at our goals and the concept of increasing the number of providers offering high-quality services. Through the Early Head Start Child Care Partnership, we're able to reach programs in 21 of our 29 classrooms. 21 of those counties are designated as rural counties. So we have classrooms in 29 of our 67 counties, and 21 of those are rural. This is a great opportunity. Usually in a rural county, they may not have what they need or the services to support this. So we are able to bring those services to the child care programs, bring those services to the families in those communities through these partnerships. We've also partnered with local agencies who have existing early Head Starts, but they had the experience and knowledge of Head Start at the beginning of this process. Our DHR, our Alabama Department of Human Resources, did not have that knowledge, but it also helped that they were right there in the community. So we would have been a little bit farther off, although we have staff who communicate, but we thought it would be helpful to have a presence in the community who knew the community as well as the child care programs did, to actually help with that transitioning from your basic early childhood standards that we have for our minimum standards and transitioning them to early Head Start standards. So many of those early Head Start agencies are also community action agencies, so they have access to additional resources that will be helpful for those communities as well. And also the layering of funding by maintaining that program participation at above 80%, we're able to target those families in our communities who really need the services, not just a transition from one service and leave another one, that they can continue to get the benefit of both of those services. And by doing that, I think we are really impacting the community. Again, Alabama, our communities, several of them are very rural. Some communities, it would be difficult for some child care programs to actually maintain services there, and so this program actually helps them to be able to do that. It has given us an opportunity to align our policies across programs, align child care subsidy program more with early Head Start, so that we are serving populations in a similar way, so that parents have less of an impact of I'm doing a dual program thing. It seems more like a one program for the parents who are part of the Early Head Start partnership. And then, of course, we see the impact, because there is actually a wide-reaching impact, and I developed this, or not developed, but I just kind of stole these phrases from our federal partners, and to look at it from Alabama, when we look at the number of programs that we're serving and the number of children that they actually impact. So when I look at those programs, that their capacity for children to serve, although we're funding 566 children, those programs have the impact of touching 1,155 children. So that wide-reaching impact means that services that we're providing to these child care programs, it's helping them with training for the teachers who may be in other classroom. It's helping them understand how they can access resources for the other classroom. It's helping us to things that we do to make improvements that initially seems like it's just an impact on that classroom. No, it's also an impact on the other children who are attending that center or that family child care home as well. We especially see that wide-reaching impact among family child care providers. Generally, you have one person or two persons who are operating that program during the day. So all the skills that we're teaching them goes from the infant toddler classroom and also can go to what they're doing with other children as well. So we feel like we're enhancing the community's ability to have quality child care, and especially in those areas that may have not been able to access those services in the past. Thank you.
Thank you so much. It's interesting, listening to you talk about this, because what you have taken is a really hard context, very rural communities where getting service delivery done is very difficult, and not only been able to reach with the specific numbers of children in the federal grant, but also to really amplify or have a multiplier effect. I think trying to help us see the importance just of when we're working on these issues of taking that bigger view and trying to maximize kind of each component so that you get these bigger effects. So let's move on and hear a little bit about the community context now in Baltimore City.
I'm glad you raised that point about the rural, much of the rural setting that Janetta was talking about. For this piece, Baltimore City is of course very urban. Some background, there are approximately 9,000 births every year in Baltimore City, anywhere between 8,500 to 9,000 births, and about 2/3 of those every year are to moms who are eligible for or covered by Medicaid. So about 5,500 to 6,000 of those births are to Medicaid moms. Some background that even just underlies why Baltimore City decided to really work on this is back in 2009, very high infant mortality rate in Baltimore City, 4th highest IMR of the 50 largest United States cities. Black babies were dying at 5 times the rate of white babies, which the picture on the right is a picture that we often show that really leaves us in 2017 with 10 empty 3rd grade classrooms of the babies that would have lived if they had lived back in 2009. A lot of the data and information that has driven this strategy comes from the city's child fatality review and fetal and infant mortality review. That's what sort of underlies the numbers that you see here. Baltimore City is a place where there are actually a lot of resources and there are a lot of healthcare options, and it's a place where people might come from around the world to seek healthcare, but we find huge disparities in the outcomes and are really seeking to address that.
Thank you so much. Let's take a look now at the context for California. We're going to hear, I think, from Karen about things that pull together across different community contexts for Project Launch.
Yes, the original launch in California was to Alameda County. So Alameda County, which is where Oakland is located, is part of the leadership team, and we'll be talking about that later. The 3 communities that are part of the expansion of best practices include San Francisco, Nevada County, and Fresno County. So San Francisco, the contracts are coming into the County Department of Public Health. It's a county-wide collaboration under Healthy Communities Together, and it's also being run in partnership with the San Francisco Mayor's Project 500 initiative, where San Francisco is looking at the root causes of health inequities, social determinants of health, a life course approach, and community-identified health problems. And their goal is to raise 500 families out of poverty through this initiative. There's a part-time mental health consultant who focuses on parents and children referred to the San Francisco Nurse Family Partnership and the MCH Field Nursing Program. And they are building partnerships with First 5 San Francisco to support the family cafe work in the county. Next slide. In Fresno, which is the middle of the state, and it's a primarily more rural county, particularly the areas that are being served, is collaborating with their local behavioral health care system. They're providing mental health services to parents who are served in home visiting programs, including the Black Infant Health Program in Fresno and Babies First, which is federal Healthy Start funding aimed at reducing perinatal mortality and morbidity. And they also are operating family cafes to promote family leadership and engagement, again in partnership with their First 5 in Fresno. Fresno. Nevada County, which is in the Sierra Nevada range, it's where the Donner Pass is located. Those of you who know the history of the original pioneers coming gold rush across the Donner Pass and getting stuck up there. So the county is split in half by the Sierra range, and in the winter it's often impassable. It's part of a local community collaboration with Nevada County Public Health Department, First Five of Nevada County, and then a nonprofit, CBO, Foothills Truckee Healthy Babies, which runs their McVie Maternal Infant and Early Childhood Federal Home Visiting Program. The home visiting program focuses Healthy Families America, which is, again, funded by McVie through a partnership with California Department of Public Health and First Five. And the family cafes are also supported through a partnership with First Five Nevada and Launch. These are three really, really different communities with significantly different referral resources, and the populations being served are also very different, with Fresno being in the Central Valley, a lot of farming community, Nevada in the Sierra Range, and San Francisco being an urban city really rich in resources and partnerships. And the family focus, as I've described, also varies a bit from region to region, with Fresno really targeting the African American community to reduce the health inequities, San Francisco targeting urban poverty community comprised primarily of African American and Latino families, and Nevada County serving really a Caucasian rural community living in isolated regions. Thank you.
Thank you, Karen. So I think we've seen here that there are a lot of disparities in the communities that everyone is trying to reach. And one of the ways that people are doing this work, which you can get just from their overviews and from the context they provided, is actually by focusing on collaboration and partnership. All three initiatives involve multiple partners, and they place a really big spotlight on collaboration. So I've asked everyone to share a bit more with us so we can get a deeper sense of, given the variations in the context and some of the differences in terms of where they're trying to head in terms of their overall strategy and support, to go deeper into that. So we're going to start again with Alabama and hear a little bit around this really pretty awesome and impressive group of partners and collaborators who are working on the initiative.
Right, and I think as in Alabama, as a statewide grantee, we had this opportunity to actually partner with some statewide agencies as well. We needed that reach because of the number of counties that we're in and how the programs are spread out across the county. So having organizations who had a statewide reach, they didn't have to change their catchment area in order to be able to reach and give the assistance to the programs that we're working with. I already mentioned that we partner with 7 Head Start agencies and early Head Start agencies as part, and they are working with our 20 centers. So again, those are also community action agencies. So they are more localized. They give us more that local opportunity to know what's happening there in those local agencies. But we also partner with Auburn University for our Family Child Care Hub, and they are partnering with 50 family child care homes as their child care partner. One of the things that made that one actually work for us is that through our CCDF program, we already had an initiative with Family Child Care, a mentoring program to help programs become accredited. So that was a great fit for us for the Family Child Care programs to actually bring over some of the things that we were already doing with with Family Child Care through that mentoring program and actually build on that when we're going through our early Head Start child care partnerships. Alabama Department of Public Health, we go through what we call care coordination, and we have social workers there who assist the parents with access to services, medical homes, dental homes, other services, WIC, whatever they may need as part of our family engagement, but also a part of making sure the parents are accessing the resources that they need. This is especially wonderful for our programs who are in more rural areas who don't have the access to resources, that they can help them, point them in the direction they need to go, find the resources for them. And also they do follow up with the parent to see how it go. Were they able to make the contact? Was there anything that prevented them from being able to make their medical appointments or their dental appointments? what are there any specialized services that they need and how they can connect them to those specialized services. Our Alabama Department of Early Childhood Education is also our pre-K site. It's also our pre-K agency. And so one of the things that we're doing is making connections there and utilizing some of the same tools that our pre-K services were using. So as children transition from our early Head Start and they transition to 4-year-old programs or pre-K programs, then we have been using the same kind of data, collecting the same kind of data. We use the TS Gold assessment, and they also use that. We're using a practice-based coaching model for our teachers that Department of Early Childhood Education is helping us implement, and then also the creative curriculum. They're helping us with the training, but it's allowing us to align some of the things that we're using, so as we move children through the programs at every level, then we will have data that can translate across each age level for the children. Also, it's helpful because there's a great focus in Alabama on our pre-K, but working with early childhood education helps that understanding of the needs of infant toddler. They understand that need as they also talk about what their needs may be for when the children turn 4 years old. Our Infant Toddler Professional Development Network is actually funded through our CCDF, but our Early Head Start Child Care Partnership Programs also has access to the standards and have access to the services that our Infant Toddler Network is offering as well. So again, that's part of collaboration, but it's also a layering of funding in that we're utilizing our CCDF funding with a program that already existed and making that program available to those child care partnership sites, the mentoring, coaching, professional development assistance that they would have, making sure that we target those programs, those infant toddler teachers in those programs. And then our other two CCDF-funded, our quality enhancement agencies, where providers go for all of their health and safety training, CPR, first aid, scholarship programs, inclusion support, all of those programs are made available so to make sure that their programs are aware of that. So we see that these are our child care programs that have been in community. These CCDF-funded initiatives are still available for them. So we're making sure that they have access to that. I've talked about our subsidy program enrollment by making that at 80%, policy alignment, and then we give priority placement. So if there is a waiting list, child care partnership children are not on that waiting list. We look on a case-by-case basis, and that's part of them who receive priority for service. They're not subject to the waiting list, so that we are able to move those families into child care. So our collaboration and partnership is a combination of starting something new, but then continuing on with what we had before. We follow as closely as possible with our Head Start performance standards as far as our governing and how we represent that. So we have representation from state, tribal agencies, community representation on our governing committee, and our policy council. And I have to say how proud I am of our policy council and the work that they do and how they have, just the questions and the comments they make as we present things to them for approval, how they are really, really coming alongside. And that's great because our policy council is made up of parents. And so we're seeing how the parents are engaged in wanting to know and wanting to contribute and how the program operates. As a state agency, we are unique because we have multiple state and federal funded programs as part of our DHR state agency. So our governance structure was a little different in how we set that up. We did not replace our DHR board, but where the governor serves as that board chairperson. So we did not use our DHR board, but we brought together representation according to the Head Start standards. But we also, in order to be able to address the unique financing and legal things related to our own agency, our assistant finance director is part of our governing committee, and also we have one of our DHR attorneys who's part of our governing committee, because we did want to have someone who understood the uniqueness of being a state agency and could address those as part of our governing body. So being a state agency brings some uniqueness to it, but I think it also brings some advantages to us to be able to access other statewide agencies as becoming a part of the work that we're doing through the partnerships.
Thank you, Jeanette. I just want to underscore how much innovation and persistence is required for the state to take on this early Head Start Child Care Partnership role, and you can see it all the way into the services where the family and children are, up to trying to figure out how to get the federal requirements to mesh well with state government requirements. So this is really a big deal in terms of escalating a commitment to really making improvements for young children. We're going to turn next to Baltimore, and Jenna's given us this really nifty organizational chart to help us to understand partnership and collaboration in their context.
Sure. So this slide is a little busy, but I think I can walk you through it so it makes sense. This is pretty much a 50,000-foot view of the range of partners involved in Be More for Healthy Babies and how they fit together. Again, this is a city-focused effort. It is led out of the Baltimore City Health Department and led in a collaborative way with about 150 to 200 different partners that range from other public agencies to academic institutions to funders to nonprofits or community groups. So what is illustrated here is how each of those partners fits in a different kind of way according to their strengths towards the long-term outcome of reducing the infant mortality rate. So over on the left, that light blue box, it says FEMUR and CFR teams. Those are the monthly meetings of the Fetal and Infant Mortality Review and Child Fatality Review teams, which probably everybody on this call lives in a jurisdiction where those FEMUR and CFR teams operate. And what they do is they review unexpected cases of fetal, infant, or child death, and they do that in a confidential manner. They look at the data, they look at vital statistics, they do case reviews for each of these deaths and develop recommendations to prevent this happening, any kind of child death or fetal or infant death happening in the future. And so this is here really to show that this is where the baseline data comes from, where trends are identified, where potential policies might be identified, and where some recommendations come out. I also want to stress that you can see each of those arrows there is double-headed, so there is back and forth communication between each of these groups. The steering committee is that gray box at the top. That is chaired through the Baltimore City Mayor's office. This particular initiative is now on its third Baltimore City Mayor and its fifth Baltimore City Health Commissioner, so it has weathered some transition. These members of the steering committee, this group meets quarterly. These are generally the political leadership of the city, the heads of agencies, the heads of nonprofits, managed care organizations who can really move their organizations in support of different recommendations that come out of child fatality and fetal and infant mortality and out of the community teams that are in the box towards the bottom with the purple shading. And Be More for Healthy Babies has funding that supports intensive community mobilization efforts in two communities, one on the east side of Baltimore City, which is very diverse, has a large Spanish-speaking population as well, one on the west side of the city, which is probably 99% African American, that has had historically one of the highest infant mortality rates in the city. And just since April of last year, there's been a community advisory board put in place of community residents from all over the city. And the purpose of this chunk is, of course, to make sure that community voice is is at the table, and that community members are able to share their feedback, their expertise, their experience of systems and programs and providers, and have that be in the mix. Now over there on the right at the top, you can see that darker blue box. That's the core implementation team, which has been meeting every Monday afternoon since September of 2009. Every Monday afternoon from 3 to 5. So after this webinar is over, I'll just scoot over to join that team meeting. These are more of the middle level leaders in several of the main partner organizations. It's about 20 people who come together, and they have more the long-term professional expertise and the technical areas of expertise. And then below that are the various different coalitions where many other partners participate on different topic areas, whether it's home visiting, preventing substance-exposed pregnancies, etc. And that's where the sort of theory and the overall strategy gets operationalized according to those 4 levels that I mentioned earlier. What can we do in policies? What can we do with providers? What can we do at the community level and individual level? One on there is called Family Literacy, and that has been renamed actually to the School Readiness Coalition, and that's where many of the partners that Janetta was just mentioning fall in for Be More for Healthy Babies. That's Head Start, Early Head Start, other home visiting programs, child care, city schools, pre-K, infants and toddlers, etc. So I hope that that gives you a sense of the big picture. And if anyone is interested in follow-up, I can give you a list of the specific partners that are involved in this.
Thank you so much. Let's now take a look to understand a little bit more how these issues around collaboration and partnership are addressed in California.
So in California, we have an overall leadership level team, which includes the California Department of Public Health, which with the California Home Visiting Program underneath it, and that's the lead. Alameda County Maternal, Paternal, Adolescent, and Child Health, which was the original county for launch. First 5 Alameda County, which was in the original partnership, and WestEd Center for Prevention and Early Intervention, which was also in the original partnership. And these organizations work together for the overall direction of the project, resource sharing, evaluation of the project, and training and technical assistance. And the expansion counties, I've already described the primary partnerships earlier that include behavioral health, First Fives, public health, and specific other government and non-governmental collaborative projects. The partnerships are really critical to success. They provide the buy-in, they build momentum, they enhance our referral processes, and they create relationships at a really different level and help to stretch the really small amount of dollars that are typically allocated for such complicated services. Without these kinds of partnerships, the programs could absolutely not operate. Next slide. In all participating counties, including Alameda, we're working to create shared leadership at multiple levels, and this includes the family level, where we embed family cafes, national parent leadership trainings that occurred actually last week in D.C., local family leadership building, and representation of family members on oversight councils such as community advisory boards and the state interagency task force for the home visiting work group of that. At the community level, we're building partnerships with key community organizations to share responsibility for the service delivery, for family referrals, for trainings, and to support sustainability. And then at the systems level, we're doing all of these things in addition to incorporating other child and family service organizations that are important to successful implementation of the services and the delivery of services and sustainability. And this includes things like the California Launch Training and Technical Assistance Team, the California Center for Infant, Family, and Early Childhood Mental Health that leads an endorsement system for mental health professionals, including the mental health professionals important to consultants that are important to our service delivery, the county departments of public and behavioral health, and the county departments of public health. Again, to have success, the shared leadership is really crucial. Sharing leadership allows partners to feel invested in in the process. It contributes in meaningful ways to the addressing pitfalls and roadblocks along the way, and also allows us to change paths as needed and determined by local issues, because every community is unique and sometimes strategies need to be changed even though there was a model out of Alameda. It also really is important to incorporate families and home visiting program staff both at the director level and service delivery level to provide additional opportunities to better understand and address the challenges that come up and to make the appropriate modifications in the delivery of services, because administrators may not understand ground level issues that families and service providers encounter. So we view partnership and collaboration as really crucial and sharing leadership as being critical to success. Thank you.
Thank you, Karen. I think that we've seen across all of these, and Karen put a really special emphasis here, that the collaboration and partnership work is everywhere. It's directly with families, it's within community, and it's at the systems level in order to help all of this really great work to happen. And you can see that it's actually complex and requires people to actually be nimble and creative in pushing the work forward. So one of the issues that is of interest, I think, to everyone about this work is really equity empowerment. And we heard different ways that the initiatives have taken this to account into their core design. But we wanted to go a little bit deeper into this, and so I asked Karen to kick us off in addressing this issue, first starting with California.
In California Launch, we're focused on health disparities and family empowerment through the elements we're using in Launch. That includes mental health consultation, family cafes, and the systems work. And we all know there are significant stigmas attached to mental health services across the country, across the world really, in addition to the disparities that we all see in terms of availability and access to mental health resources. So our mental health consultants are working directly with home visiting program staff to provide linkages and referrals for longer-term mental health services for families, and they may also provide short-term interventions directly in family homes in collaboration with the home visitors, thus breaking down some of those barriers around getting a referral to mental health and a new person and all of that. These disparities in terms of access are maybe more evident in specific regions, for example, in our rural areas, or with specific populations. So we've seen this particularly with our Latino families in California who may not be documented and have no access to free or low-cost mental health services. So this was the rationale for selection of the regions we've included in the expansion. Next slide. Through the Family Cafe work and Launch, we're building family empowerment and strengthening families. It's based on strengthening family system and issues and supporting the development of family leadership, particularly in underserved and isolated communities. So many of our communities are isolated. We want to reach those families. The goal is really to reach those underserved populations and empower those families. There's also a frequent sense of what is termed selfless obligation in providers of home visiting services that leads to compassion fatigue, burnout, and attrition, and then that leads to family attrition. So the provision of mental health consultation can also help support home visitors as they work with families who have significant mental health needs and to reduce the vicarious trauma that they may experience. Thank you.
Thank you, Karen. Now we're going to turn a little bit to Baltimore, and as Jen is getting ready to talk, we're getting really wonderful questions in the chat box, and I want to encourage people to keep putting them in. Some we will actually have answers to because they're built into the presentation. Some are more specific, and if we don't get to them during the webinar, we'll get you answers post-webinar. So please keep communicating with us as we're going through the presentation. Jenna, do you want to talk a little bit about these issues in Baltimore?
Sure. Thanks, Harriet. And I was tracking some of the questions specifically, which I think are good segues into this particular set of slides. Two of the questions were about are parents formally involved in the systems leadership work and how to better engage community members with different services and programs that exist. I don't know if, just to remind folks of what I was explaining at the beginning of this, is that in Baltimore City, the black infant mortality rate back in 2009 was 5 times worse than the white infant mortality rate in Baltimore. Just to give you a little better sense of the population, about 65% plus of Baltimore City's population is African American, and while the majority of the rest of the 35% is white, there's a growing population of Spanish-speaking and Asian residents of Baltimore City. However, a lot of what's here around race equity is really framed more in terms of black and white. I think the big thing that I wanted to stress in these 2 slides is, while this effort really was undergirded at the beginning with really clear data, matching birth and death certificates, really looking at those case reviews that I mentioned before, having a good sense of national best practices, really landscaping out what programs and services exist and where they don't exist, where there are gaps, etc. What BHB has really been trying to move much more intentionally into is having more community partnership, having more community demand for different things, and having the initiative itself be held accountable to the community. And so the Community Advisory Board, which is referenced here and which I referenced before, is made up of about 14, 15 community residents who are from all around the city. Some have never been on a board before, some have been on a board before, some have been professionals and are now retired, and some are, moms who are in the community and really working week to week with their children. Those advisory board members are stipended. They were all recruited. They all applied. They all were interviewed, and they're all stipended for their time. They have transportation, food, child care provided to attend those monthly meetings. They're really helping Be More for Healthy Babies look at the policies and the systems and the services that are offered. Do they resonate with Baltimore City residents? Are they welcoming? Are they culturally appropriate? Who is the messenger for different programs? Who's a recruiter? And so really looking at a lot of those things and trying to make some changes so that, as someone asked, that there is additional incentive and demand for participation beyond a gift card. And also really looking at the workforce. If you know that a certain percentage of the population is actually very difficult to find and engage, whether they're eligible for early Head Start or home visiting or a pre-K program, who are the messengers that are going out and recruiting for those programs? Are the materials that are developed, are they written in plain language, appropriate literacy level, etc.? And so trying to look at all of those things. The next slide is really a statement of purpose around race equity. This collaborative of many partners agreed to this statement. This collaborative has offered about 4 different race equity trainings for the variety of partners that participate: public leaders, funders, nonprofit, and community residents. Each of those trainings has had about 40 slots. They've all been full. We have about 5 more of these trainings scheduled through June for 40 people in each, and that's really helped, I think, the many different partners at many different levels in their organizations have a shared kind of language around this piece on having community leadership partnering with, and not either being tokens or just giving input and then going away, but really working in partnership, and how to really help look inside at all of the work that we're doing and making sure that it actually is appealing to and motivating for residents.
Thank you. Janetta, why don't you wrap up this conversation around equity and empowerment, and then we're going to turn to something that we're getting a lot of questions in chat about, which is what are our impacts and expected outcomes. Before, let's hear a little bit more from Janetta on this topic.
The partnerships in early Head Start, one of the great aspects of that is its ability to especially empower among parents and also children. So Head Start has a history of seeing families and children transition through their system into other areas, and so I think that's one of the things that we wanted to kind of focus on as well. The partnership programs gives us this great opportunity to impact underserved communities and families who may not have had the same level of access to services. And by doing that, we have this opportunity to create unique partnering with child care partners in areas and in places where we can actually impact those underserved communities. So we have classrooms that are located in or near public houses that makes that access to those services for those residents much easier. The travel and all of that is much easier for them. We also, in one of our programs, they have a memorandum of understanding between the public housing organizations and the program for employment opportunities for residents of the public housing. So that also is helping them, empowering them there in positions that they qualify within that child care development program, that there is opportunities to employ residents of the public housing. And then special needs, and we know that all of our sites are striving toward having special needs children included, but we also have some sites that have a very special emphasis on serving special needs children. And so we are able to accommodate that through the partnership program, that we can have those classrooms that have that special focus on children with special needs, and the same way with families who are homeless. One of our sites is this site is actually built so that there is a homeless shelter, but there is also a child development program that operates there, and so residents there have a program right there in the same site where they are. So that gives them better access to those services. And so when you see the way we were able to make those connections for families, the services that they're accessing, getting that child care services as well, and then the additional things that these programs are able to bring to those families and children. And then one of the things that we've been doing since the beginning of our program, we started with a Parent Leadership Academy. It initially started as a focus on our Policy Council members, our parents who are member of the Policy Council, to help empower them and to help them understand their role as a Policy Council member. But we have expanded that in the last few years to include all parents, to include parents from our Child Care Subsidy Program, as well as our Early Head Start Child Care Partnership parents. And this year, our planning committee is made up of parents as well. And so rather than us as a state agency saying, hey, this is what we want to present to you, these are the things we think you may be interested in, they're giving us the input and what, as parents, they want to be, they would like to hear about and like to have workshops related to help empower them, not just as parents of their children and helping in their children's education, but what do they need in general? What do they need to help them stay strong and help them with any challenges they may have just in their general work environment and other environment, including their own personal health and staying fit. And so that is something that we have incorporated Parent Leadership Academy to help empower the parents as part of the Early Head Start Child Care Partnership Program, but through their comments, and we're expanding that to include other parents, hopefully foster parents, as well as additional parents who are participating in our Child Care Subsidy Program, using some of our foundation funding and other layering of funding again to bring all that together, to bring those services and to help in ways that, you know, we may not be able to do just with one funding source alone, but through the combination of funding, through the combination of services, we're able to create these unique opportunities to bring quality child care services plus quality impact to our families.
Thank you so much. So I think we can hear across these initiatives that there is a lot of time and effort spent to creatively basically look at issues around empowerment and engagement and a lot of focus here. Now, I want to move us along to talk about impact and expected outcomes because we've had questions in the chat about this. And so I've asked everyone to talk about what they see as impact and expected outcomes. And as we get into this section, I just want to remind people that California and Alabama are earlier in this process. Baltimore's been at this longer, and so we're going to have a higher level just overview from California and Alabama, thinking about impacts and outcomes from a systems perspective. And then we are going to actually be able to look a little bit more data-oriented in terms of some of the work in Baltimore City because it's got a longer life that it's been going on. So Karen's agreed to kick us off to talk about this issue for Project Launch in California.
So in California, we're expanding the mental health consultation model beyond what has been traditionally seen in the past, which has been focused on delivery in center-based preschool settings such as Head Start, to home-based service systems where mental health consultation is desperately needed. And we're also building skills of home visitors to support families with mental health issues, to hold them until they can access more intensive services and to feel effective in this really complicated work. So we're hoping that these models for infant, family, and early childhood mental health consultation in-home visiting will be available to other regions, not only in California, but across the country. And in that vein, we're presenting at national meetings and doing webinars and that sort of thing. Secondly, we're really working on strategies for an integrated approach to using family cafes for family engagement, support, and leadership building, and we hope to be able to share those kinds of strategies. And our family cafe outcomes that we're measuring and looking at are increased rates of family engagement in home visiting programs, increasing parent connectedness to needed resources and within their own communities and to each other, creating communities of families, and aid in the client's transition from home visiting programs to other community programs when home visiting ends, and to help identify and support parent leadership opportunities. And our family cafes include any family member. So grandmother can attend, dad can attend, auntie can attend. It's not just focused on moms like some cafe models in the past have been. And thirdly, we're really trying to document systems changes supporting integrated services so that they don't exist in separate buckets, that we have them work together. However, gathering data in this integrated fashion across partnering organizations can be a challenge because of disparate databases that we all face. So that's a quick and dirty.
Thank you, Karen. All right, let's do the same now for Alabama. Janetta, do you want to talk a little bit about impact expected outcomes?
Yes, and I think because, Harriet, you mentioned the multiplier effect, and I think that's one of the impacts and outcomes that we are actually seeing with the partnership programs, and that the impact on non-early Head Start child care partnership children that are served in the same program. And that's one of the things that we wanted to see. And so we're seeing that just by how those programs are restructuring how they do everything, not just for those early Head Start classrooms, but they're restructuring, and we're seeing advances and changes in the way they approach quality child care for their other classrooms as well. I think one example in one of our programs, using the Head Start model, the program itself has hired a family services worker for their program. That's something that you don't always see in a child care center, that's one of their staff members, but this program has chosen to do that. So now that family service worker is not just available to the early Head Start children, but they have someone who's available to all the children and families in that program. So that wide reach and impact, that multiplier effect, is something that we're seeing. I thought also it'd be great to just see what our providers are saying about the impact. And so the Empowering Parents, one of our family child care providers, states that parents are becoming better educated, more confident, not only as parents but also as members of our community. We see that from our policy council members, but we're also seeing that at our local parent committees. Our family child care providers also have local parent committees. And so that is also something we're seeing, that perhaps programs did not do as often or did not stress as much the impact of having parents communicate and have and being able to give input in the operation of the center. So not only just as that child care program, they are more empowered to talk about early care and education, talk about their needs with their community leaders, as well as talking to their child care provider. And then helping our children achieve. And one of our programs, a child who did not talk or participate with his peers is now doing the simplest actions, but the teacher says, I am most proud of him laughing and smiling. These acts alone make the teachers so proud of what they do every day to help children. When we're seeing the impact that when the teachers see the impact that this program and operating a program at this level of quality and this level of weight and the involvement of the parents, how this impacted children, it is also having an impact on the teachers as they understand the work they're doing, the importance of the work they're doing, and they start to see that difference being made. And so they are striving more as well. We started this program with less than 50% of the teachers having achieved the CDA requirement and higher than that is required. We right now have more than 70%, or we're right at 70% of our teachers are meeting all of their education and professional development requirements. We actually have about between, I think about 35 and 40% of our teachers who have a bachelor's degree or higher. And so we are building that capacity as well, but I think the most important thing is that they are starting to understand the impact that they have on children's lives and how that impact on children's lives transition into the rest of their ability and their school readiness. Even though we're doing infant toddlers, they're understanding how that moves them forward through their pre-K time to their kindergarten time and to their school time, and so they are just happy to be a part of that. So those are outcomes that we're beginning to see right now in our, went from, I think, now I say that we are toddlers in this infant toddler work because we are moving into our 4th year. And so it's just great to see the impact that is happening there. And I think the greatest perspective to see those impacts and outcome is to see what the parents and what the providers are actually able to communicate about what a difference this has made in their program.
Thank you so much. So I think using that math, Baltimore's project might be an elementary school. So let's hear about kind of, I think that's right. I might be slightly off by that, Jenna, but this is grounded, of course, in public health. So we have an awesome amount of data here that we're going to get to look at to kind of understand something about outcomes and impacts in Baltimore.
Right. So this slide is a summary of those long-term outcome results between 2009 and 2016. Just a reminder that there, as I said before, there's a refresh going on now to sort of project out to say 2023 or 2028, so 5 or 10 years from now. The overarching comment on this is that there is a partner group that does the monitoring and evaluation for Be More for Healthy Babies at those multiple levels of intervention that I mentioned earlier, the policy, the services work, the community, and the individual. Many of those short and intermediate term indicators of movement are very similar to the examples that Janetta and Karen offered just now. So there is quite a lot of overlap in what those look like. So for example, you might have, the Home Visiting Coalition is looking at, the enrollment and retention of clients in home visiting programs, and also the enrollment and retention of staff in those home visiting programs, because that has an effect as well. And the monitoring evaluation is done that, we have for the short and intermediate term indicators. We might have surveys, we might have other data tracking devices, but these long-term outcomes here are from vital statistics. So we get them from the state, and generally it takes about a year or so to get those. So if you go to the next slide, that is the infant mortality rate slide. There's been an overall 35% decline in infant mortality since this shows 2005 to 2016, but the 35% decline has been since 2009. The infant mortality rate was trending upwards from 2005 to 2009. There's been a 64% decrease in the racial disparity between black and white infant mortality rate. The green is black, the red is white, the blue is all IMR across Baltimore City. So there is still a disparity. It's about 2 to 1 now, but it's not where it needs to be, but it is much better than where it was in 2009, which was at 5 to 1. If you go to the next slide, that speaks to the teen birth rate. Again, this is a rate slide. 49% decline in the teen birth rate in Baltimore City. 75% decline in the black-white disparity. In Baltimore is the red line there that's kind of all over the place. That is the Hispanic/Latina teen birth rate. There are smaller numbers. That population is much smaller in Baltimore City. So with changes there, the rate jumps around a whole lot more significantly. But even with that, this work realizes there's a lot to be understood better about that particular population. We do find that among the Spanish-speaking moms, there is not so much an issue with infant mortality rate, but as you can see, the teen birth rate is higher than the others there. If you go to the next slide, this is representing numbers as opposed to a rate. Deaths, sleep-related deaths were one, I don't know if you remember, but sleep-related deaths were one of the main drivers of the high infant mortality rate in Baltimore. We do see that as a very preventable issue. The sleep-related infant deaths have decreased by 71% since 2009, which has really been down to an all-time low in 2016. That has just been tremendous and really important, and has involved everything from policy changes in hospitals to citywide things that the mayor would do, to really working with providers. Someone asked about providers and making sure to work with pediatricians and really engaging staff at all levels in the message around safe sleep, sort of treating it a little bit the way you might treat seat belts if you're trying to get people to change behavior around that, and making sure there's consistent messaging, and also having a pretty robust and community-informed communication campaign about safe sleep practices that featured women who had lost a child due to unsafe sleep, and then a couple other videos that were really for male caregivers and for older caregivers. We did not have funding for those campaigns last year, and so there's a little note here that says there's been an uptick in 2017. So the preliminary numbers show that the decline after 2017 will not be quite as steep as this. The next two slides are also rates, preterm birth and low birth weight rate, which often go together. They are much harder to change. They have decreased slightly, not a huge amount. We collectively feel like we've done the things that are certainly hard, but are maybe less complicated than changing preterm birth and low birth weight. And there's been a lot of work done by the health department and by the fetal and infant mortality review team to look at where those, what's driving these issues of preterm birth and low birth weight. And they often have to do with stress-related hypertension, preeclampsia, things like that. And the disparity between races for these is quite large, and we think has a lot to do with generational exposure to racism. So I'll leave it at that.
Okay, thank you, Jenna, for sharing that. You can see the great impact this project has had, and you can also see just from the things you've already shared, of course, that you took a really strong multifaceted approach and involved people in multiple parts of the community and in multiple roles, but you can really visibly see the payoff on some of this public health data. I'm going to have us talk a little bit about financing because you can already get a sense listening. These are complex initiatives. They are involving multiple funding streams, and so I'd like to make sure we give everyone the opportunity to talk about those. I think if all goes well, while we had more slides we had prepared, after we do this set on financing, I'm hoping we'll have a little bit of time, and then I'm going to go to the questions that have not been answered in the chat box and pose those to our panelists. And then if we do have time, we'll go back to the rest of our slides, but you will get all of the slides if we don't get to them. So our next issue really is, well, where are the funding streams? People have talked about layering, braiding, blending. And so let's just hear a little bit from Alabama about where the dollars are coming from to be able to make this work out for Early Head Start Child Care Partnership.
Funding, I think, to the level of quality that we want for child care programs, this aspect of layering funding, different funding sources, I think is very key for the partnership program. So, of course, is our Head Start fundings, our CCD of Child Care and Development Fund through the Child Care Subsidy Program. But I think also you have to consider with your CCDF things that may be already happening around quality initiatives to help you meet those professional development goals you have for your teacher and for your staff in the Child Care Partnership programs, that there is an opportunity to actually use those funds as well. Foundation funding had been key for us, especially among the startup and doing some innovative projects, an opportunity to see how innovative projects work in an environment that may lend itself later to us using more of our federal funding as appropriate to help sustain those projects. And then, of course, because Head Start funds required match, and we can use some in-kind and some match. So all of those are part of what we use to finance this program to help us draw down the available federal dollars, as well as helping us to implement some of the initiatives and the requirements of the program as well. So layering of funding, I think, is a key aspect of being able to maintain this work with the partnership programs.
Thank you, Janetta. It's really difficult, as Janetta said, in early childhood education to get enough resources in to create the levels of quality that you need to. So this piece of kind of taking funds and figuring out how to braid them together is critical. We're going to turn next to Baltimore and also see a complexity of funding that has been able to be put together in creative ways to help drive the change strategy.
Thanks. And, maybe just back to the data just for a second. I think one of the things that is important to stress is how challenging it is because this relates to funding, these are all issues that we're talking about today that take a long time to make an impact, and there is this need to sort of constantly educate out and up and all around about how we need to see trends over time, and things might bump around a little bit, but what we really want to see is things going in the right direction over time, and sometimes that's harder for people to see or understand or want to keep investing in. The budget, the brief 3 quick slides on the budget content for Be More for Healthy Babies, and I just want to say this slide just sort of gives a sense of what's represented in the next 2 slides, but this budget, it's about $29 billion. It is heavily representative of the Baltimore City Health Department dollars that flow through there and dollars that flow through 2 of the main main implementation partners. It does not include the budgets of all those 150, 200 other partners. We don't have that. But for the core funds, you can see that about 95% of them are from public sources. 73% are federal, 12% city, 10% state, and only about 5% are private. Just on the private funding note there, the two main private funders, philanthropic donors, have been CareFirst Blue Cross Blue Shield, which is a regional funder here in the Baltimore, D.C. area. They gave the original $100,000 planning grant for this work, and they also have given almost $9 million over the past 9 years. They've given about $750,000 to $1 million a year to help cover things that public dollars don't cover. Everything from sort of running a coalition to doing some landscaping work to funding the communication campaigns. Annie Casey Foundation, which is where I sit, has also supported for the past 5 years or so. And those dollars, as you'll see in the next slide, really, they really make a big difference. The public dollars often are, as you can see here, 87% of the 29 million support direct services. Everybody on this call knows that you need money to support infrastructure, and then I've also mentioned the communities and systems work and the monitoring, evaluation, and the communications. Those things often are not covered by public dollars, whether they're federal, state, or city. And many times, at least we have found that a lot of people are saying, well, why aren't you getting Medicaid to reimburse this? And Medicaid often can reimburse if it is reimbursable. Even if you are maximizing your reimbursement rate, it might not cover everything that's really needed for population level impact, which is where private funding, on the next slide, there are just some examples here on the next slide of how private dollars have been helpful in and sort of moving things forward. So at least in Baltimore, they've been used for filling gaps, for sending a staff member as being on loan to the health department or to a partnering nonprofit to really help move the work, capacity building in the form of either funding a position for a period of time until public funds are identified. So for example, the teen pregnancy prevention and birth spacing work did not have a public source of funding to support it at the time for the coalition leading, and so private funding funded that for a couple years until they could identify public dollars. Strategic planning, different things like that. I think when well placed, I think those private dollars can be really helpful. Lots of times private dollars go into funding like a really well-funded pilot, which has not really been the case here in Baltimore. We've really been trying to use those really carefully so that any private dollars that go in are sustainable.
Thank you so much. So that's an interesting kind of really detailed dive for us to kind of see especially a critical way in which private sector contribution can leverage, and that the pieces together can be sustainable over quite a long period of time. Let's end with a little bit on financing in California, and I'm still holding out hopes. We have 6 minutes left that we can hear a little bit about the resources in California and then answer at least one of the questions in the chat box before we have to close for the day. Karen?
Yes. Although federal SAMHSA dollars are really funding launch and they're the primary impetus for the work that we're doing in this small region, very small region of California, the partnerships are really critical to financing the complex work we've undertaken, because the launch dollars the funding is quite small, it's relatively short term, and this is typically a problem with unstable funding when you don't have basic funding for programs. So it contributes to lack of sustainability. It also contributes to a lack of ability to really implement widely successes that you see in programs. So this all relates together. The financing relates to the sustainability, it relates to the expansion, it relates to systems integration and systems changes, and that's really important to consider. So the partner funding really includes County Department of Public Health funds that cover administrative costs, oversight, all of those sorts of things. First 5 county dollars, and the first 5, for those of you who don't know, in California is the tobacco tax initiative, so all counties get money. And then the San Francisco Project 500 initiative is bringing money into San Francisco, partnering with Launch. And finally, the county departments of behavioral and mental health, which are really critical in terms of partnership in order to infuse mental health consultation into home visiting programs. We would like to explore how to build a base for mental health consultation, because it's cheaper to do consultation than it is to do oftentimes intensive long-term direct services, and many times it's more effective. So we're really exploring how to build other kinds of mechanisms that are more long-term sustainable than just short-term buckets of federal dollars or foundation dollars. Thank you.
Thank you so much, Karen. So we just have a few minutes left, so we're going to bypass the rest of our slides, but we will be sending them to you. But there is one question I think that that came up that I do hopefully we can answer. And Tony Porter asked this question. Even with shared leadership, do you still identify one responsible agency to ensure that all of the work is moving forward? So, Janetta, let's start with you, and then we'll go to Baltimore, and then we'll end with California on that question.
And for Alabama, yes, because the Alabama Department of Human Resources is the grantee agency, so that's the agency to ensure that the work is moving forward. But, of course, you know, with that shared leadership, that's a part of what is required through Head Start. Then we are doing that with the Governance and the Policy Council, and so they are receiving the information. But, yes, DHR is that one agency.
That's great. Jenna, talk about that a little bit for the complexities of Baltimore.
So the way that Be More for Healthy Babies talks about it now, it used to be that there were really 2 lead agencies. Now that has increased to really more than that. So the way BHB will describe itself is that it is a Baltimore City initiative led through the health department with many of all these different partners. The authority definitely rests more at the health department, and whether something moves is going to depend a little bit on where the money for that something flows through. So, for example, a lot of the money for home visiting programs in Baltimore City flow through a particular intermediary organization. So they may be at a better position to sort of move the home visiting work than the health department. So it just depends on the content area that we're talking about. I will say that one of the things that's been really important here is to have a set of partnership principles and MOUs. Many of the latter, the MOUs, are still in process. For a long time, it was just a set of partnership principles that partners use to work together and to call each other on, things like shared credit and shared credit and responsibility and things like that, and transparency. But now we're really formalizing a lot of the partnerships to sort of describe MOUs. I think to have MOUs, I think it's hard though, because for anything like infant mortality or reducing child abuse and neglect or improving school readiness, it isn't on any one entity, really. It really does depend on everyone putting in their part and working together in a way that will make a difference at a population level. And so we're sort of muddling through this how do you do this? How do you reflect the reality, but also make people feel comfortable that there is one person in charge?
Thank you so much. Karen, let's have final thoughts from you before
you know
we
what?
close out
I
today's
did answer
webinar.
this in the chat box,
Yeah.
and I know we're out of time, but it's basically overall direction for the project, including things like federal reporting and data collection, falls to West Ed, but the training and technical assistance is really shared across the leadership group of Alameda County First 5, Alameda MCAH, and West Ed, and in each county the responsibility for service direction and making sure this is happening comes in under the County Department of Public Health.
Thank you, Karen. So we are now at the end of our hour and a half, and this obviously is a really stimulating discussion with pretty fantastic work from people going on all around the country. As Jen Bender said, we will make sure you get all the slides, including the slides for the questions and issues we didn't get to. We will work amongst the speakers to try to finish addressing the questions that we weren't able to address and get something back out to you. And I do want to encourage everyone to take a moment to fill out the feedback form so that we can get your input for our series and ideas that you have and ways to improve it. And lastly, of course, I really want to thank our three speakers. They put in an incredible amount of time to preparing. You can see they're doing amazing work all around the country on behalf of our really youngest children. And so on behalf of BUILD, my big thanks to all three of our speakers and to everyone who joined in today. Thank you, everyone, and have a great afternoon.